I think it's not, again, it's not necessarily that everyone here wants to prevent someone from dying who wants to die, and it would depend upon the circumstances. But there's a big difference. I think Ben said it. I don't want to be seen as critical of Janet Atkins. That was Janet Atkins' decision to seek out what she wanted, but I do feel that I can be critical of Dr. Kevorkian and would be critical of other physicians who would practice in that manner. It's not incumbent, because the patient wants to die, for that patient to come to me as a physician and say, "Dr. Fine, kill me." And my clinical practice has told me that there are many better outcomes that can be achieved for every patient I've ever run into that asked me to kill them.
Well, I think she's in a position, though, it makes it very difficult. Some people are in a position where they really are so bad off that their quality of life is almost nothing. Would you agree with that? I mean, and yet they're still basically have all their mental faculties about them. Yet there's just so much pain, so much trauma, they can't deal with it. And yet they're not strong enough or weak enough, as the case may be, depending upon your perspective, to commit suicide. If they came to you and said, "Help me," I realize that's a very difficult position, but from a doctor's standpoint?
Well, again, I can only speak from my own personal perspective, both as a clinician and as someone who's dealt with a lot of these cases in my role as a ethics committee chairperson at a large hospital. And I've not come across that situation where a patient could not be allowed to die, could not be kept comfortable while we were waiting for that to happen. I think you need to understand some history of why there's this clamoring for active euthanasia. If you look back at the roots of Western medicine, there were three things that the Greek physicians said that healers ought to do. One was they were supposed to do away with suffering. That meant to cure. The second thing they were to do was to lessen the violence of the illness, to take away the symptoms. And the third thing was to refuse to treat those who were overmastered by the illness. And what happened? For a long time, medicine did that. And then in recent years, we got confused and we stopped estimating correctly, let's say, when a patient was overmastered by the illness. And so we threw one treatment after another treatment after another treatment. And you had these horrible, prolonged, extended deaths that might take months.
And what I'm going to argue, millions of dollars at the same time.
What I'm going to argue to you is that you can cure diseases sometimes, and when you can't, you can certainly lessen symptoms much better than, as a general rule, my profession currently does. And that you can refuse to impose increasingly burdensome treatments when the patient is overmastered by the illness, and that is a preferable outcome both for the patient and for the profession of medicine than simply saying, so you want to die today, here I am, here's your injection, have a nice eternity. I don't think that's going to be a good thing for patients or for medicine. And if I could respond, sure, again as a physician, I think that from the point of view of what I would see as best for all patients and for my relationship as an individual practitioner with any potential patient, is that I may, as a private act, as Professor May spoke of early on, if your suffering seemed so horrible and I could not control it and I couldn't give you any quality of life that you found acceptable, and frankly I find that I've not really run into that problem taking care of patients at all ages, dying from all types of unfortunately horrible diseases. But if I ran into that problem, could I, as a private act, do that? Yeah. And I think a lot of physicians can and do. Does that mean I think it ought to be legalized? No. Okay. Because I think in our society that will be horribly abused. We abandon people. Euthanasia would be an easy way to abandon people. We do things to excess. We would do this to excess. If you look at the Netherlands experience where they have illegal euthanasia, it's against the law, it's simply not enforced. They've got a very different society there. Everybody has health insurance. Everybody goes to a nursing home. Nobody's tied down in that nursing home.
They have real options.
We don't, yeah. In our society, there are too many patients. I had a young man with AIDS, couldn't get Medicaid, couldn't afford his drugs, said, "This is horrible. I want you to kill me." We kept him alive 3 years with a very good quality of life. When he said to me, "This life is not worth it anymore," we allowed him to die. And he did not suffer one bit. So On a private basis, yes, I can see your point, but I think it would be very harmful for us to make it legal in our type of society that can't even take care of the bare necessities.
Chaplain?
Again, I would think, and I think that it's done, that you can arrange that in those rare circumstances it not be botched, it ought to be humane. I would put a patient like that on a hospice, frankly, and I would use a morphine drip, and I would make sure that patient did not suffer. And that's a very viable option that many physicians will do, and there's a difference still between that type of act with a terminally ill patient and what's been alluded to, or what Kevorkian did. I mean, if you talk about botching it, well, Kevorkian didn't botch it, but I cannot think of a worse place to die than in the back of an old beat-up VW van without my family in attendance. I don't want to be painted as inhumane. There are ways to help patients as private moral acts when it is necessary. My clinical experience has told me, though, that I generally do not have to be in the position of breaking the law, and I don't think it's good to change the law in a way that would allow kind of wholesale, active euthanasia, killing the patient as a means of ending their suffering. There are many other ways to amend or end suffering.
All right, here's a question up here.
Any of us are really in a position to play God.
If I could make one response to
right
re-emphasize that there are ways to control the pain, and that is what frightens many patients. The other thing that frightens them is being left alone. And I think another way to help the patient who is terminally ill and who says, end my life now, I don't want to go through this, is say, no, I will help you go through this. I will make sure that you don't have pain, and I will also make certain that you are not alone. I will be there for you. And I think that that's something that if physicians did more, patients wouldn't be clamoring for active euthanasia.
Thank you. Got here in my hand, Dr. Fine, it's something called Issues Surrounding Critical Illness Personal Choices, published by the Baylor University Medical Center. In the back of it, it has a, I guess what you would call a short form, a living will directive to physicians. This is a fairly new publication of Baylor. Tell us briefly what it does and what the viewing audience out here could get from something like this.
Our ethics committee became interested in this a number of years ago when we would be asked to provide a consultative service when there was some dispute between family members or family members and physicians about whether or not some particular medical therapy should be withdrawn from a critically ill patient. And we realized that we were kind of coming in as the firemen after the fact and decided we needed a little bit of preventive ethics, and the way to do that was with communication. So through a research process that involved visiting with citizens of this city as well as our own clinical experience, we developed a brochure designed to arm patients with information so that they can talk to their doctors about what's going on in the modern hospital, so they know what the terminology means and what their options are for controlling their therapy. And in doing so, we're trying to foster communication so that a patient who wishes perhaps not to have some heroic life support used can communicate that idea to their physicians and the healthcare team. And we put these in every waiting room. We pass them out wherever we can, because the more information we can know about the patients we serve, the better we can serve them.
Thank you. This is Philip McClure of the Hemlock Society.